Hello, everyone, and thank you for joining us. This is Dave Iverson. I'm the contributing editor at the Michael J. Fox Foundation and the host on today's webinar. The webinar today is part of our ongoing Third Thursday webinar series, where each month we take up a topic of importance to the Parkinson's community. And I think today's topic is a good example of all of that, a topic that obviously matters a lot and perhaps just as obviously doesn't get talked about perhaps enough. And in a very real way, that's our goal today, is to just open up that conversation. And as part of that, in this webinar, as with all of our webinars, you play a key role in posing questions that you would like to see answered. So we hope you'll submit your questions on this topic. There's a Q&A box in the middle of your screen where you can type in your question and submit it. And we'll do our best to answer as many of your questions as we can over the course of the hour. And because we no doubt won't be able to get to all of them, we're also going to offer, as we often do, an extra opportunity to get your questions answered. That will take place at 12 noon tomorrow, 12 noon Eastern tomorrow on Twitter. We'll continue the conversation on Twitter. The hashtag is FoxPDChat. A couple other quick notes and then we'll get started. You can download the slides from today's presentation as well as our other resource materials. Just go to the box that's labeled Resource List and you'll be able to take care of that there. And last, we want to also be sure to thank our sponsors, Acadia Pharmaceutical, Medtronic, and Teva. All right, let's get started. Here's what we're going to cover in our webinar today. We're going to talk about the sexual changes that happen to both men and women with Parkinson's disease. We're going to talk about other aspects of Parkinson's that may impact your sex life, not just perhaps the motor symptoms or the autonomic symptoms of the disease, but other aspects of living with Parkinson's that may affect someone's sex life. And we'll talk some about Parkinson's medications, the impact that they have on sex drive or sexual activity. And then, of course, we're also going to spend some time talking about the treatments that are available, both medical, pharmaceutical, and other kinds of treatments that can be useful in dealing with these issues. And so let's meet who's going to join us on our panel conversation today. We have a great panel lined up, and I'm happy to have them join us for our conversation. We're going to be joined by Karen and Mark Jaffe of Cleveland, Ohio. Karen is a retired OBGYN, retired just a few years ago. She was diagnosed while still in her 40s with Parkinson's disease in 2007. Her husband, Mark, is a writer and, in fact, penned an article which I recommend to all of you to reading about how the Parkinson's diagnosis affected their sex life, a New York Times piece that's in our resource list. So, Karen and Mark, thanks both very much for being part of our conversation today.
Thanks for having us.
Pleasure to be here.
And joining us as well is Dr. Jeff Albaugh. He is the Director of Sexual Health at North Shore University Health System, serving the greater Chicago area in Illinois, and has made a particular focus of his practice assisting people with Parkinson's disease contend with various sexual issues. Dr. Albaugh, thanks for being with us as well.
Thank you so much for having me.
And we also hope to be joined in a bit by Dr. Daniel Weintraub. Dan is an associate professor of neurology and psychiatry, which you can see on your screen at the University of Pennsylvania. But Dan is busy right now in clinic helping patients, and so we hope he'll be able to join us at some point during our hour. But let's get started with our topics, and we're going to turn first to talking just some about the prevalence of this issue. And I want to give all of you just a moment to sort of take in these statistics. I think they're really quite telling that some studies suggest that as many as 70 to 80% of people with Parkinson's experience some aspect of sexual changes or sexual dysfunction. And then on our Fox Insight survey, our online survey at the Michael J. Fox Foundation, of the 2,000 people who have participated in that, sexual issues, particularly erectile dysfunction and reduced libido, were the top most bothersome non-motor symptoms of the disease. So it really gives us some sense of, I think, how prevalent these issues are. And Dr. Alba, let me ask you to comment on that first, about how common this is an issue, because I think, among other things, for people with Parkinson's who are contending with this, it's reassuring to know, at least, that you're far from alone.
I think that's absolutely true. I mean, some of the surveys have showed that as high as 85%, and your statistics of 70 to 80%, I think, are right on the money. Certainly, people will have sexual issues as they age, but patients with Parkinson's disease have certain particular problems that they complain about, and I'm not surprised, because the most common thing that brings men to the clinic is erectile dysfunction, which was cited in your from the people in your Michael J. Fox Foundation group with your online survey. And then reduced libido is the number one complaint of men and women ages 18 to 59 anyway, so it's a common issue. But these things can be more common in Parkinson's disease, and we'll talk more about those specific things as we go along with the webinar today.
Thanks, Dr. Alba. Let's move right into some of the most common problems that people experience. And we're going to begin with the sexual changes that happen with women, in particular with Parkinson's. You see them on the list, everything from desire to arousal to inability to achieve climax, and even the problem of sexual pain. And I want to bring in Karen Jaffe for a comment on that first, and then I'll come back to you, Dr. Alba, for more. But Karen, as someone who had a long and fruitful career as a OBGYN, I suspect that as a gynecologist, you dealt with a lot of people with some of these issues. So I think it's also perhaps useful to put this within a kind of context that while these problems are perhaps more prevalent with people with Parkinson's, these are issues that women struggle with perhaps more in middle age than we sometimes realize.
That's true, Dave. And in my practice, in the GYN literature, the incidence is probably quoted as about 60% of women will complain of sexual issues, although I would tell you that on some days I felt like every woman in my practice had it on their problem list. And so the most common complaint that I would see across the age groups was this lack of desire, so to speak. But pain with intercourse was not far behind, especially as my patients got older and went through menopause. So they're the similar problems, but obviously the numbers for the Parkinson's group are higher than this, so it speaks to the disease itself.
And Dr. Alba, of these that you see on the list, Karen mentioned in her general practice that reduced sex drive and pain were among the more prevalent that she saw. Is that true in your practice as well for people with Parkinson's?
I think that is definitely true. I think that the number one thing that probably brings women into my office, both women with Parkinson's and other problems, is the pain issue. Because if women are active and they're having trouble with pain during intercourse, that can be distressing for patients. Desire is a tricky thing, because when you don't have desire, sometimes it may not be something that you would seek out help for or necessarily ask about, even though it is certainly the most common problem, a lack of desire. In many men and women, it's not always something that they'll seek help for, because that lack of motivation, that lack of desire for sex, makes it also more difficult to ask for help with that or to seek help for that. So I think I certainly see desire issues, arousal issues, trouble with orgasm, and sexual pain. But I would say the number one complaint that usually brings people in to seek help is probably pain, even though desire is a much more common issue, as all of the research has shown. It's not something that will necessarily bring somebody into the clinic, and so that can be a little tricky in that respect. But I certainly see women with both desire issues, and oftentimes if you have pain, it affects desire. If you can't orgasm, it can affect desire. So I think that's why desire can be affected by so many aspects, even just our incredibly busy lives. Desire can be a real issue.
And are there, Dr. Alba, aspects of Parkinson's? We see the footnote at the bottom of the screen that says that Parkinson's affects both the central nervous system, the motor issues that are so common in Parkinson's, but also the autonomic nervous system, meaning the more automatic parts of our physical beings, the way we breathe, blood pressure, things like that. Can you say something about why Parkinson's makes some of these problems more acute?
Well, I think it's multifactorial. There's a lot of reasons for it, but I think probably something that is important for people to realize, especially in terms of desire, is that desire can be affected in a couple ways because of dopamine in the central nervous system, and dopamine is prosexual, but depending on what's going on, some medications may increase that dopamine and make a person more hypersexual, and some things may decrease or suppress the dopamine, especially some of the antidepressants and some different medications may do that as well. So depending on what exactly their treatment course is for the Parkinson's and some of the other things that can accompany Parkinson's disease, then they may have either decreased or increased sex drive accordingly, depending on what's going on with them. But that can be one of the main factors in sex drive, and then plus all of the other, some of the motor symptoms can affect just being fatigued and lethargic, or not having the energy level for sex. There's a lot of different things on both sides that could affect desire, and certainly in the autonomic system, where the main, in the lumbar thoracic area, where the main things are housed, the main centers for your sexual responsiveness in terms of both orgasm, arousal, things like that, those things can be impacted by the effects on the autonomic nervous system as well. So there's certainly Parkinson's disease affects it in multiple ways, and I think that that's important for people to understand, both centrally through some of the neurotransmitters like dopamine, and then autonomically through the spinal cord and through those centers that are so important to sex there as well.
Let's move on and talk to some about the sexual changes that happen with men and see sort of what common denominators there may be. And again, of course, we're going to talk in just a little bit about the various things you can do to contend with all these problems. And we want to get through kind of the list of all of the things that people do contend with. And we see again on this list, Dr. Alba, some similarities. Problems with achieving orgasm, problems with decreased sex drive. So first, are men and women mirror images, I guess, of each other in this particular area? Obviously, the physiology is different, but do you know what I mean? Is the effect of Parkinson's sexually on men and women essentially the same?
I think that there can be issues in the same areas like desire, arousal, orgasm, and things like that. But I do think it manifests itself differently in men and women. You know, men and women are very different in some ways, but similar in others, and I think that's why you see some similarities. One of the huge similarities is the lack of sexual desire or libido or sex drive, and you can see that in both men and women clearly. And then difficulty reaching climax, that's going to carry over on both sides because neuropathy or nerve damage and medications that alter sensation like pain and pain medications as well as psychiatric medicines or mental health medications can affect your sensation to be able to orgasm. So those are going to go across men and women both, and problems may occur with ejaculation with men and women, orgasm with men and women, and desire. One thing specifically that I would say is the number one complaint of men with Parkinson's disease is difficulties getting and achieving an erection, which is the definition of erectile dysfunction, inability to get or maintain an erection sufficient for sexual relations that you're trying to have with a partner. So I think that's a definitive difference with the men, but otherwise, yes, there is a lot of overlap in what men and women both struggle with in terms of desire and orgasm, as well as even some of the pain issues.
And specifically on the question of erectile dysfunction, again, a problem that's common in the general population, especially as men age. Is it more acute? Is that problem more acute in Parkinson's than older men in general? And if so, is it, again, because of some of the things you were outlining before about whether it's the lack of dopamine or other things that happen physiologically within Parkinson's?
Well, that's an excellent question, and I think the listeners are probably very interested in those answers and I think it's important to put that research in context of what happens with the general population as they age, as they have other common health issues that people struggle with in America. And the thing is when we look at patients that are in their 60s and 70s, a good half of those men will have erectile dysfunction, is what studies have shown. And so when they've looked across the country at our cross-sectional studies, they found that a good half of men will have erectile dysfunction. Why? Well, they think some of it's due to the aging process, but even more the common issues that happen in patients as they age, and in people as they age, such as diabetes, cardiovascular disease, increased cholesterol, increased blood pressure, obesity, things that happen often in the later decades will cause erectile dysfunction in those men as well. So that's important to remember, that it's not just Parkinson's patients, but if you look at those statistics of 70 to 80, 85%, that is higher than what they would expect in the other populations. And so we know that it can be more prevalent, but it may be due to other things that are going on in the Parkinson's patients. If they have elevated cholesterol, they have high blood pressure, or they have diabetes, this can compound things further, because many patients, the majority of patients with diabetes, high blood pressure, will have erectile dysfunction as well. So it could be the Parkinson's, it could be some of the other things they're struggling with, and it could also just be the aging process. And the same thing going back to the women, and I'm sure that Karen can speak to that as well, that as women age and go through menopause, normal changes will occur and desire will often drop off, as well as some of the pain issues that happen from hormone changes or tension in the pelvic floor. So men and women both will experience sexual dysfunction quite frequently in these later decades.
Let me ask you one question about what can be done. We're going to get to more of our answers in the second half of our webinar today, but since we're talking specifically about erectile dysfunction, a number of people are already writing in and wanting to know whether or not the standard erectile dysfunction medications, things like Viagra, Cialis, for example, whether or not those are effective for people, men with Parkinson's, and if they're safe for people with Parkinson's, both in terms of the disease, but perhaps also their interaction with other medications. Quick thought on that, Dr. Alba?
So first off, thank you so much for your questions, and I'm happy to answer that question. First of all, it is safe. There are a few contraindications. There are a few, especially men who take nitrates for chest pain and things like that. But Parkinson's patients in general, many Parkinson's patients will take these medications. They're called PDE5 inhibitors, which is just a fancy name for medications like Viagra, Levitra, Cialis, Stendrastax, and all of these medicines that are designed to increase the chemicals in your penis that help increase blood flow, so that when you're aroused, and only when you're aroused, you can get harder potentially. When we look at men with true erectile dysfunction from Parkinson's and physiologic things, these medications probably work, we find in practice, in about 60 to maybe 65, 70% of patients. So they don't work for everybody. Do they work in Parkinson's patients? Excellent question. And the thing is yes, they can. But just like everybody else, they may not. And why is that? Remember that if the communication between the brain and genitals is not working properly because of neuropathy or nervous system problems that can be associated with Parkinson's disease, if the communication isn't clear, then the genitals don't know that they should become engorged because they don't know you're excited and aroused. So if there's some neuropathy or you're on medications that affect your ability to sense things, it may be more difficult to get and keep erections. It also may be more difficult to climax. But I certainly think that these first-line treatments that most men choose as their number one choice, which is the oral medications like Viagra, Levitra, Cialis, and Stendrastax, that these medications are worth a try, and they may work. And remember, in this population, studies show that they can be effective, and so you have just as good a chance as anyone else of them working for you, but they don't work for everyone, so there's nothing, don't feel like, what's wrong with me, why aren't they working in me, because they don't work for everybody, but they're worth a try. Remember, when you take these medicines, a couple super important pointers. They are affected by food and fats, so you want to take them on a fairly empty stomach. You want to once you take it, they'll start working in 30 to 60 minutes, but if you want everything it's going to give you, don't forget you're going to want to wait about 90 minutes for the full blood effect, especially of the classic three, Viagra, Levitra, and Cialis. So a couple pointers that will help with improving efficacy, and then they may or may not work, but certainly are safe, and many patients with Parkinson's take them unless there's a reason that your provider says no, and those reasons are not real common, but you can have contraindications.
Great. Thank you. That's very helpful, I know, and useful information for everyone listening who's wondering about that particular question, which of course is so common. And we'll get to many more of your questions in a moment. But we want to move ahead and bring back Karen and Mark Jaffe into our conversation and talk about a couple of other issues. And then we'll start in taking all of your questions in about 10 minutes. And this one has to do with the medications that are often prescribed in Parkinson's disease and how some of those may impact one's sex life. The first bullet point is that some of the medications that are sometimes prescribed for depression, something that's very common in Parkinson's, can also lower sex drive and impact sexual performance. But what we really want to get into next is this question of other kinds of drugs that are used for the motor symptoms of Parkinson's, dopamine agonists. In particular, these are drugs like Requip or Mirapax are two of the common ones. And they're sometimes associated with hypersexuality, very frequent or strong sexual urges. And I want to bring Mark and Karen back into our conversation at this point to help describe their part of this story. And Karen, again, as a gynecologist, I know you, as you were saying before, dealt with many patients, many women who felt like their libidos were not matched very well with their husbands. And I remember you telling me once that you could identify that. So first, if you would, before we describe what happened when you started taking Parkinson's meds, tell me something about what your own sex drive was like before your Parkinson's diagnosis and before you started taking Parkinson's medication.
Well, you're right, Dave. I mean, it was very much like my patients. I would come home and, Mark would be complaining, and I'd say, well, I've been listening to the same story all day long. But in a nutshell, it often felt like I just didn't have the energy to make intercourse happen. I was busy with my kids, work, life, which led to an inertia that I just could not get past at age 47, 48, 49.
And then you got a Parkinson's diagnosis, which of course changed your life, Mark's life, and your family's in many, many ways. But perhaps one of the more surprising ways that diagnosis changed is when you started taking the drug Requip. Tell us what happened then.
So I was diagnosed with Parkinson's disease, and immediately I was started on Requip as the drug to treat my tremor. And I don't particularly remember that visit. I was overwhelmed by being seen that first day, so I don't remember being told about the side effects of this drug, although I think Mark will tell you that we were warned. But it only took about a month or two for us to notice that inertia that I talked about was rapidly becoming a thing of the past.
We were not only warned, but I specifically remember and was rooting for it to happen.
So he was pleasantly surprised for a while.
And you can be as specific or graphic as you choose or don't choose to be. But what was the difference, Karen? What did you feel? What happened? Tell us a bit more about what changed for you and Mark.
Well, the best way that I think I can describe it, Dave, is that, when women in my practice, including myself, have this low libido, there's a sadness that comes along with it because we remember times when it wasn't such, and that and people would always ask me, how could I get back in the club? How could I get back to where I was, where I wanted to initiate intercourse and be a part of that? And I didn't have any magic wands for anybody. So, it was to have that come back and all of a sudden feel like, I was ready and willing, and then not only that, but initiating these things, it was great. But, unfortunately for my husband and I, he thought it was great too, but we were also keeping my Parkinson's diagnosis a secret. So while it was really fun, he wasn't allowed to tell anybody. So, but I felt like I was back in the club, so to speak, like I felt when I was younger, and that was a really great, and I also couldn't tell my patients this, and they all wanted, so I would go back to my office, and now all of a sudden I had I could still empathize with them, but I also knew that I had this secret in my pocket.
And Mark, from your and Mark, sort of pick up the story from there, both your initial response and then something about what began to happen as the demands became even more than what you had once dreamed of.
Well, I think in any good relationship, the sex in the relationship will be something that is always in flux and being negotiated between the two people, and I think in a good relationship, obviously both parties want to please each other and do the best that they can in that regard. So, it was a challenge for me as Karen's with her low libido, and then with this pleasant surprise of all of a sudden being interested again, much as we were when we first met. It was kind of like a second honeymoon period, and I was thoroughly enjoying it, and felt, look at this, we're matched again, so to speak. We're on the same level, and it was great. But Karen had to continually, because of the Parkinson's, up her medication, and whether that was it or just the hypersexuality that she started experiencing just kept getting further along. Her needs outpaced mine. And so suddenly we were kind of on the opposite ends of where we had been a year or two before. And, she wanted it much more than me. And not only that, as that, having been on the other side and knowing how difficult it was when the other party wasn't satisfying you, I felt like my responsibility was to not let that happen. I needed to keep up with her as best I could and do as much as I could to not let her go wanting. And so that's all kinds of pressure that I realized kind of maybe what she felt on the other end when I was the one who was begging for it. But it manifests itself in erectile dysfunction and in just the lack of desire and all those things that I couldn't believe I would ever have. So here I was on the other end, and after a couple of years, and found myself having to explore all the options that we've been talking about earlier that Parkinson's patients have to face.
And as you write about in your New York Times essay, and again, I do encourage everyone participating in today's webinar to read Mark's essay. It's funny, it's personal, it's in the end quite lovely, really, and a lovely tribute to their relationship. But as you write in that, Mark, in time things sort of came back down to a more even keel. And Karen Jaffe, was that just the kind of course of time, or did your movement disorder specialist adjust your medication accordingly? How did that sort of get you back to where your libidos were once again matched?
Well, it's an interesting question, Dave, because the truth is, unless my movement disorder specialist had seen the play that Mark wrote about this or read the article, this was not anything that was ever discussed with my movement disorder specialist. So that was, because it's a tough subject to talk about. And I think that probably I'm still on the same dose of medication, and I'm a much more even, sexualized person, but I think it probably has to do, I can't be sure, maybe Dr. Alba can make a comment about this, the fact that at the end of, over the past 5 years or 4 years, I've gone through menopause. And so that probably is perhaps what has tempered some of it. I can't be sure. But I think that if I had probably mentioned it to my movement disorder specialist in terms of how much it had affected us, I'm sure he would have taken me off the medication. The truth was that I didn't really want to come off my medication because despite the fact that it was causing us some problems, my medication has worked well for my Parkinson's, and so I've just been reluctant to change that. to change my prescription. But for us, it has worked out that we're back down to a much more normal level, and so I guess it's not an issue anymore from that standpoint. But
I tend to think that part of it is the realization of the effect that it was causing on me, and that knowing that, she was able to refocus her energies. I think the medication still has some obsessive compulsive behavior that Karen will experience in other areas of her life, but she somehow was able to refocus to those areas which, although they still may affect us, it doesn't affect us in to the extent that the sexuality affected us.
Well, Mark and Karen, thank you for sharing your story. And again, if you want to read Mark's essay, there is a link to it in our resource list. And we'll bring you both back in just a few minutes as we start taking our audience questions. We need to move through a few more slides. Dr. Alba, I'll come back to you in a bit and ask you perhaps to comment further on the medication adjustment question and with these dopamine agonists in particular. But let's review a couple of other points and then we'll dig into your questions. We've already talked about this some, so we'll just spend a moment on this, that there are other aspects of living with Parkinson's that can affect one's sex life, from depression to sleep, even things like, that frequently in Parkinson's you have a bit of a facial mask, and so it makes it harder to express affection, the impact that this can have on self-confidence. All of these things we wanted to put out there in these slides because these may be things that you're experiencing. You may not really think about the connection that it might have to one's sex life, but it's worth considering that. And as Karen, I think, just importantly observed, it's also worth considering talking about that with your movement disorder specialist. So all of these things come into play as well. Let's spend just a moment or two talking about potential treatments before we start taking your questions. We've see here on the screen, Dr. Alba, a variety of things that can be done. I'm not going to ask you to go through each one for time reasons. We'll pick up on any of these specifically when we get to our audience questions. But in general, I think the important point we want to make on both this slide and the next one that we're going to show is that there are things that can be done. This is not something that you just have to live with. There really are options.
Absolutely. I think that's the really good news, and so I hope that gives hope to the people out there. Certainly knowing that they're not alone, and then also that there can be some treatments. But first of all, I think it's so important, just like many of your listeners already know, every treatment has pros and cons, good and bad. So you have to decide, is the treatment right for you, understanding the good and bad of each treatment. Just like the treatments you take for Parkinson's and other health issues that you suffer with, these treatments have positives and negatives. But certainly we've talked some about some of the oral agents, the PDE5 inhibitors, such as Viagra, Levitra, Cialis, Stendra, and Staxin. There's also a new medication that has come out for women. It's not widely available because there's some special training that people have to go through to prescribe it so that we make sure it's not abused like some of these medications can be. But it's a medicine that is supposed to help with libido. It's a dopaminergic medicine. So it's going to be something you have to carefully look at with your provider and see if it's right for you. It's specifically for women. The generic is called flibanserin, but it is going to be available, and you might want to talk to a provider about that. It's exciting that we have a new drug for women because we have a few things we can certainly use for pain in women, but not a lot of other medications to treat sexual issues. First of all, it depends on what is your issue. Is it a desire issue, arousal, orgasm, or a pain issue? And then we do have very specific treatments for each of those things. Vacuum devices, you may be kind of miffed by what is that, but there are vacuum devices that help pull blood into the penis for men or the clitoris for women. We have devices for both men and women, and they can help with bringing more blood into the genital area to help with arousal, sometimes with orgasm and things like that. Physical therapy specifically can be very helpful in patients who have pain. Not only can there be hormonal issues, as Karen alluded to when she was talking about menopause and the lack of estrogen and even testosterone in women in the vulva area, specifically the vestibule, the area right outside the vagina. As you separate the labia and you look, that pink area inside is the area I'm talking about, can get inflamed, can get painful. And so we can deal with the hormone issues in that respect, but also physical therapy can help with some of the muscular issues of holding tension in that pelvic floor. And then surgery. Certainly there are some surgeries for different specific problems like erectile dysfunction, even some surgeries for the pain issues and things like that. Again, we don't have time to go into the great detail of this. We just wanted to mention that there are a myriad of different treatment options that are very specifically addressed to the problems that you're having. Same thing, I know someone had asked about premature ejaculation, and I'm part of the way through answering that question for you online. But again, most importantly, we're talking to the listeners. But there are specific treatments for that, and you need to talk to your provider about those specific treatments. Lots of different things depending on what the issue is. Again, make no mistake, there are pros and cons to every issue, so you have to decide, do the benefits outweigh the risks? Do the good effects outweigh the side effects, and is it something you want to do? Sometimes it can just be even the cumbersomeness or the awkwardness of it that can be challenging with something like a vacuum pump. But if you can get over and through some of those things together with your partner and incorporate them into love play, there are things that can effectively help you enjoy intimacy, which most human beings crave and want, that communication on all levels, as well as sexual things like orgasm and desire.
And in addition to all of the things that are on this slide, we also want to make sure we mention that there are things that just have to do with better communication, issues of timing, being able to talk and get help that can play a big role as well. And these are all important, and we'll open up and talk more about those issues as well as all of your other questions as we dig into that now. So lots of questions, as one would expect, and let's sort of go through these the best we can and see how many that we can get through. There are a lot of people talking and asking questions about achieving orgasm, in particular. Erectile dysfunction, of course, is part of that on the male side, but not the only part of having orgasm. What about for women, Dr. Alba? What is out there that would help in that regard for women?
Well, there's a couple things really that we have to understand. First of all, sometimes it can be more difficult for women to reach climax or orgasm anyway, because with the clitoris being an erectile cylinder similar to the penis but buried inside the body, sometimes it can be more difficult for women to reach orgasm. And we know that women primarily orgasm from clitoral stimulation. It doesn't have a lot to do with what's in the vagina or stimulation directly in the vagina, but for the majority of women, and there are exceptions to every rule, it's about clitoral stimulation. So it's important to understand the anatomy and sometimes just learning where the pleasure comes from, what type of pleasure feels the best there and helps bring you to orgasm can be very important. Usually that is oral, manual, or vibratory stimulation on the clitoris. But every woman's different. Don't assume anything. And the best lover is one who really wants to understand and know, what does my partner really want from me? How can I pleasure them? And how can I provide what they really need to reach climax? So I think that's a huge part of it, is just understanding and knowing. If you're able to climax with something like a vibrator and not other ways, you can also maybe climax using that vibrator while you're having penetrative sex or other types of sex with your partner. You can incorporate it in. So I think there's definitely things that can be done to treat it, both behavioral things, also just some education, learning your own anatomy and what can be most helpful. But when it goes beyond that, there are also some topical things we can do to increase sensation and ability to climax. As I said, there's a new medication coming out. Now, whether that will help so much with that or not, we're not exactly sure. It's mostly targeted at desire, but it may help some with arousal as well. So I think there are definitely things that can be helpful. But what has to happen is you have to sit down with a healthcare professional, a sex therapist, or a sex specialist to work on that. We deal with patients holistically. We deal with the physical treatments as well as the behavioral treatments and things like that. But certainly there are treatments specifically for the men and women with difficulty climaxing. It can be tricky, and sometimes medications can be shifted and changed so that we can, so it's easier to reach climax. Especially some of the antidepressants can delay climax, and so when that happens, sometimes we can work closely with the prescriber to adjust those a little bit, adding things like bupropion, Wellbutrin in, or switching things around so that you're able to climax again. It can be
and
tricky.
Dr. Alba, I'm sorry to interject, but
That's okay.
we have lots of questions, and so I'm going to ask you if you might, to as complete and helpful as your answers are, I just want to make sure we can get through as many questions as we can. So I'm just going to encourage you to be brief in the time we have remaining. Here's a question that I would like Karen perhaps to tackle first from your experience, Karen, as a gynecologist. Someone writing in saying, are there things that women can do to alleviate pain during intercourse? You were saying that was a problem you dealt with frequently as a gynecologist.
Well, and that's something that is easy to bring up to a gynecologist because they're used to these kind of sort of issues, and usually women and their gynecologists have these personal conversations, so it's less likely as a taboo subject. But it depends on the woman's age. Certainly, there are women who are postmenopausal who have issues with pain merely because they're postmenopausal and their estrogen levels are quite low. And the vagina is one of the most sensitive organs to that estrogen loss. And many people, even before they go completely through menopause, will complain of pain because of a low estrogen state of their vagina. So usually the physician can evaluate that. Sometimes it has to do with a smaller caliber as a result of menopause. And so the physician can do an assessment quite easily during their exam and come up with solutions for that patient.
And Dr. Alba, a question about whether there are any medications for premature ejaculation. Again, something that can happen in the general population commonly as you age as well.
So certainly there are. The two categories of medications are desensitizing medications. So things like Promescent, which is a desensitizing spray. So these are numbing medications. They can work sometimes. Layered condoms. You can, as you go along, you can add or subtract a condom to decrease or add sensation. So I like the layered condoms work quite well because if you put 2 or 3 condoms, that will decrease sensation and you can last longer. There's some behavioral things that we work with as well. There are no specific medicines besides the desensitizing medicines specifically designed for or FDA approved for premature ejaculation, but we do use some medications off-label, and just like we talked about earlier, those are some of the psychiatric medicines and things like that that delay climax. So you have to work with your provider on a solution specifically for you.
Question about erectile dysfunction, Dr. Alba, and prostate health. Is there any connection between the two?
Well, the nerves for the erections lie right on the back of the prostate. I was just sort of starting to answer that, so thank you for bringing it up because I'm trying to get to some of those questions as well. But so there's not a direct link with something like prostatitis for men with Parkinson's disease so much, but certainly infection of the prostate can happen in anybody, and so if you notice signs of that infection, you want to see your provider. Someone else was asking specifically about prostatectomy, which is a treatment for prostate cancer, and because they have to peel the nerves off the back of the prostate, many men who have their prostate removed or radiated will have erectile dysfunction specifically, as well as some other issues maintaining and getting erections and things like that. So there's not a direct link, but many men as they get older will suffer with prostate issues, enlarged prostate, possibly prostatitis, which is an infection, or prostate cancer.
Question that maybe Mark and Karen you can comment on, which just has to do with the problem sometimes of intimacy when you're also dealing with so many other aspects of the disease. This person is actually particularly asking about if you're in more a caregiving situation. That's not your situation, of course, Mark and Karen, but I wonder if you could talk, perhaps Mark, from your point of view, a little bit about when your partner has a condition like Parkinson's and all that comes with that. How do you deal with that well, communicate with that well? Because there may be times when that affects your own level of sexual desire because you're looking at your partner as someone with a condition as opposed to necessarily your spouse.
Yeah, well, there's certainly is that. I think it's a matter of as a caregiver, there's certain, if it's a woman for a man, there are certain nurse outfits that sometimes are.
Stop
it is a challenge because it's certainly a major part of what your relationship becomes, and so you do have to take that into account. But I think throughout my life, whether even before Parkinson's, I think it's a matter of attitude, and you have to remember that this is the person that you married, and it's a person that you love, and that there's all different aspects to that person throughout their life, and so there's going to be, I don't know. For me, it's just a matter of attitude, and you know that everybody has different things at different times that are going to play a more primary role. So it's a matter of adjusting and realizing that the other person is not their disease, just like the other person is not their job. Or,
right.
I'll jump in to say that.
Karen, can you, just jump in if you would, too, please, Karen, and about the importance just of communication in general, with your partner, not only in this aspect of marital life, but just in general, that this only increases, I guess, the need for communication.
One of the things that Mark said at one point in our, was that having Parkinson's, was, from his standpoint, was hard because he didn't know whether he should he felt like a new lover, and that he wasn't sure whether he should take my hand or not, and to steady it, there's this tentativeness that he has to deal with my symptoms, and so it changes how he looks at me to some degree, because he's not sure exactly how much I want him to, reach out to me when I'm symptomatic or whatever. So it does. So you do have to keep the lines of communications open, and that obviously is dependent on that you have a working relationship before the Parkinson's diagnosis. But it kind of sort of also brings up the point, Dave, that for Mark and I, granted things got out of control and they were really kind of wacky for a while, but at least we were headed in the right direction. I mean, imagine a situation where a couple where there's a mismatched libido, and the prescription that they've been given even creates more of a mismatch. A woman's got a poor libido, her husband has Parkinson's, and now he gets put on Requip, and his libido is even bigger than it was. And so that can really lead to a lot of havoc in a relationship if they're not communicating about what's going on. So it's important that we kind of accept that this is a very common situation for many, many couples, and that really they should bring it to the attention of their movement disorder specialists, because I think that's a place where they can start to get answers and some solutions that they don't necessarily have to go it alone. So,
thank you for raising that, and Dr. Alba, just come to you on that for a moment as well, because while Karen and Mark have found a balance with all of this, it is true that sometimes these agonists can really create, as Karen says, havoc in a relationship, lead people to pursuing extramarital affairs, compulsive sex in ways that just aren't healthy. What do you counsel in that regard so that problems like this don't get out of hand? Don't happen always by any means with some of these agonists, but they can happen.
Well, I think it can be challenging, but there's a lot of really great support groups that are available that can be helpful for some people. I think working closely with a sex therapist, you can find a sex therapist through AASECT, AASECT.org in your area. That can be really helpful as well. It just depends. And remember, having a disparity between a person and their partner in sex drive is not unusual. It's very common. So there may be a disparity, but is it causing real distress in the persons or the relationship, in one of the individuals or the relationship, that's when it's time to seek either relationship therapy or individual therapy, and possibly work with one of the local support groups for sex addicts, and if that's the particular issue.
A couple of people are raising questions, Dr. Albaugh, about more natural remedies, or whether there are foods that you can take in that might increase desire. Comment on that?
So I think that first off, I would say be very careful of some of the herbs and some of the remedies out there, because a lot of them can be costly and ineffective, and some of them can be dangerous because they contain drugs and testosterone and steroids and things. So you have to be very careful because they're not governed. Now, make no mistake, I do believe in vitamins and herbs and things like that, but you have to be very careful. So in terms of natural things, there are all kinds of things that can increase desire, and you alluded to some of, they're working closely with a sex therapist or someone on some behavioral things, because desire exists a lot in the brain, can be really important. That's one thing. But I do think that a really in terms of foods and things like that, there are a few things that are said to. There's not a lot of research to support whether it does or not, but if you find something especially sensual or sexy, sometimes people find that in things like chocolates, sometimes people find that in finger type of foods and enjoying things like that, sometimes people find it in other things. I think that makes all the difference in the world. I do think that in terms of sexual health, it's very important to have regular exercise and really do a heart-healthy, low-fat, low-cholesterol, plant-based diet. But increasing desire can be tricky. But a lot of it is keeping it novel and fun between you and your partner. And that can really be something that can be incredibly important. Does sex always happen exactly the same way with the same pattern, or can you mix it up a little? Where will it lead today? Will it lead to intercourse or oral or manual? That should be a bit of a mystery, because mystery builds desire, no doubt about it.
A number of people are still raising questions or concerns about the difficulty in achieving orgasm. We've talked about this a couple of times, but it seems to be something out there, Dr. Albaugh, that people would really like some more guidance on. Anything else that you can offer for that question?
Well, again, I just think so much of it is learning. Is there a way you in particular can reach climax, and how can you incorporate that into what you're doing with your partner? For most people who have trouble climaxing, when you masturbate or self-stimulate, that's an immediate feedback system between your hand or what you're doing and your brain. And so that's the best way to learn, because there's a constant communication between your brain and what you're doing to what's working and what does not. If other things don't work, what some people say is, and not always, again, it doesn't always work, but adding vibration, which taps into a different part of your neurologic system, may help along with other things you're doing. You may try different settings. You may try intermittent, but does vibration in any way help? There's not really a specific drug that's going to help you necessarily climax. There are some things we can do with medications to help, but vibration is one of the few things that has been shown that it may or may not help with some people in reaching climax. Again, it's a hard question to answer, and I don't want to take up too much more time, but you have to go individually and see what medications are you on, what's impacting it, peel apart the onion, and then treat each of those pieces to determine how we can get you to climax.
A couple of specific questions we should try to get to before our time comes to a close. One person is asking about deep brain stimulation, something that is often done in Parkinson's somewhat later in the disease course, so that practice may be changing, and can be very effective in helping with some of the symptoms of Parkinson's, including a tremor in particular, though it's not something that fundamentally alters the course or progression of the disease. Have you had any experience, Dr. Albaugh, with people who have received deep brain stimulation, and whether or not there is a connection between that, be it positive or negative, and sexual performance?
I haven't specifically. It's too bad that the other neurologist is not on, because, but in my practice, I haven't had patients come in specifically for those reasons, and I haven't had specific anything specifically with that.
Okay,
This is
fair enough.
Dan.
We'll try to. Yeah. Oh, Dan, you're on. Great.
Yeah, I sent an email, but I didn't want to just jump in at the wrong time. So
This is Dr. Dan Weintraub, neurologist at the University of Pennsylvania. Sorry, Dan, we didn't realize you were with us. So please
that's
go
okay.
ahead.
It hasn't been so long, and I'm I wish I was a neurologist in some ways, but I'm actually a psychiatrist. But do have enough experience with all the treatments. So, and I think DBS would only have an impact on sexual drive and performance in the sense that it allows adjustments to be made to the Parkinson's medications after the surgery if the DBS is successful. I don't think I'm aware of any evidence that it has a more direct effect on sexual drive and performance.
Dan Weintraub, while we've got you, let me ask you another question that's specific perhaps to Parkinson's that you perhaps can respond to, which is a question about whether there's low testosterone associated with Parkinson's disease, and whether or not that in turn might lead to problems with sexual interest, sexual performance, and the like.
Yeah, so I think Dr. Albaugh can probably comment, or I know he can comment better than I can on whether there's a general association between testosterone levels and sexual performance. I'd say there's really no clear evidence that I'm aware of that testosterone deficiency is greater in Parkinson's disease patients than in the general population, not that I'm aware of.
Dr. Albaugh, anything to add?
Well, I think it is something that is cited as one of the issues that patients with Parkinson's disease describe as testosterone deficiency, but I think your point is well taken, that it may or may not be due to the Parkinson's, but it is one of the effects that is listed in the literature that can happen. And so here's the thing. As men age and as men get older, testosterone may decline. The bottom line is it doesn't always lead to symptoms. So the big thing is, do you have symptoms? And if you do and have low testosterone, then yes, it might be something that you want to seek treatment for. It's a tricky thing, and we could spend a lot of time on testosterone treatment because it's a bit complicated because it is a steroid and has benefits and risks. But in the right patient, it can be life-changing. In some people, it does nothing. So you have to specifically look in your case. But testosterone deficiency can happen in men in Parkinson's. It can happen in all men as they age and have other disease processes, and it can be treated, but you want to carefully look at it because there's risks and benefits. Make no mistake about using a steroid, so have to very carefully proceed with that.
And Dan Weintraub, one last question for you. We've talked some about the difficulties throughout our hour in talking about this, whether it's to your partner or to your doctor. Knowing that your specialty is in psychiatry, but knowing also that you've done a lot of work with people with Parkinson's and a lot of research in this area, can you say something about the importance of just talking about this, whether it's to your primary care physician, your movement disorder specialist, your counselor, your psychiatrist, but just the need to be able to have this conversation?
Right. So I think this goes well beyond just the issue of sexuality, but just in general, and in lots of symptoms that may not be easy to talk about. And I think that's the advantage in some ways of being a psychiatrist, is that we're kind of trained to bring up subjects that might be uncomfortable, to just make them part of the routine questioning and clinical management of patients, to try to destigmatize things. And that certainly applies to Parkinson's patients as well, where you may have to talk about, I heard you referencing the impulse control disorders before, that includes sexuality, but it could be gambling symptoms, eating, buying, having to discuss psychotic symptoms, cognitive impairment. These are all not necessarily pleasant topics. So my habit is always to just try to, in general, be upfront and open and just treat it as another symptom. And I think it's also crucial, and I've always made it my habit, to have the patient come in with whoever is with the patient, and even to encourage them to bring in a spouse, caregiver, child, adult child, so that you're getting as much information as possible and there's not a level of secrecy that you're encouraging. And for the most part, that works out well. And I think patients, it makes them feel more relaxed, and family members, about discussing issues.
Dan Weintraub, thank you, and thanks for joining us for this final portion of our webinar today. The last question to you, Karen Jaffe, before we have to bring this to a close, maybe to Karen and Mark, both of you, but just I guess a brief word of advice, if you care to give it, for everyone listening. As a couple who has worked your way through some challenges, what would you say to others who are struggling with this as a couple, whether it's the particular problem you experienced or other ones, that can lead you back, as Mark was saying earlier, to remembering why it is you're married to that person, and why love, I guess, can still flourish?
Well, for me, I would say, and I'll let Mark finish it off, is that, we've always seen, we try to, look at the brighter side of things and have a sense of humor. And even in some of the hardest days that we've had, and we've had plenty of hard times with this diagnosis, is that at the end of the day, you've got to be able to, see the humor in things. And so maybe that's easier said than done when you've got a husband who's a comedian. On that note, I'll let Mark say his final comments.
Well, I won't say anything funny. I just say I think that along with the sense of humor is a sense of optimism and probably a thankfulness that if you are having some sexual issues with a spouse, then you have a spouse to go through the diagnosis with is a better thing than not having somebody with you. So.
Well, thank you both. Thanks, Mark and Karen, so much for being part of this conversation. It's a great contribution, and I know we're all appreciative of it. I also want to thank Dr. Jeffrey Albaugh, who provided so much information throughout our hour today and did so in such a candid and helpful way. Dr. Albaugh, thank you very much.
Thank you.
And Dan Wantraub, appreciate you jumping out of clinic to be with us for the end portion of our webinar. Thanks to you as well.
Sorry I was so late.
No, we were glad to have you. We'll be sending a link to all of you so that you can listen to this show again on demand or share it with other people. We'll also be sending a survey link so that you can tell us what you thought of this particular webinar and your suggestions for how we can improve in the future. A reminder that if we didn't get to your particular question, that there is another opportunity on Twitter tomorrow to continue that conversation. The hashtag is FoxPDChat. And we also want to just say that a couple of words about our next two webinars, actually. We're adding an extra webinar next Tuesday. So just in a few days, this is a special webinar we're doing to talk about what we've learned so far through our online survey tool, Fox Insight, about what that's telling us about individual experience with Parkinson's. So that's next Tuesday, September the 22nd at 12 o'clock Eastern. And then our third Thursday webinars will resume, of course, next month on October the 15th, when we're going to review the latest news about what's going on with drug trials, drugs that we hope may be able to either slow down or stop the progression of Parkinson's disease, which of course is the big goal. Some fascinating clinical trials going on right now, and we want to give you the latest about what we're learning on that. That will be our topic on Thursday, October the 15th. Thanks to our sponsors, Acadia, Teva, and Medtronic. Thanks again to all of our guests, and thanks to all of you for participating in today's webinar. I'm Dave Iverson.